Hi, this is Dr. Bhargava, and this is the next video in the series Body Imaging Case Review. This is our first slide where I'm showing you CT scans from two different patients to describe CT-related artifact. So here in the region of the pelvis where there are pelvic bones, especially at the level of the hip bones, there are a lot of artifacts here in the region of the bladder, and that's because of the attenuation caused by these bones, and because of that there is an artifact because there are not enough counts, and a lot of the x-rays are being stopped by these hip joints as they try to go reach the detectors on the other side. So this is a common artifact from photon starvation, and it may look similar to this artifact where this young female has a hemorrhagic cyst in the pelvis and it shows a hematocrit sign. You can see here that there is a hyperdensity that is layering, and so when there is blood inside a cyst, the components will settle down and give rise to a hematocrit sign. So know the difference between a artifact versus a hematocrit sign. This is our next patient, and we are looking at multiple images from their CT scan where there is a complication from a laparoscopic, a gastric band that is seen right here. Part of it, and the subcutaneous port is right here, and you can see that this port is disconnected from the tubing. Tubing is far away from it, and the site where we inject the saline to inflate or deflate this band, that has been disconnected from the catheter. These are two images from a patient where a lymphoscintigraphy study was performed, and at first glance on the image on the left you may feel that they have a breast cancer and there is a sentinel node in the internal mammary region, but that's not the case. If you look at the lateral view, you would notice that the site of injection is in the upper back on the close to the midline, and that's where their melanoma was, and the lateral view shows that the sentinel nodes are lighting up in the right axilla. So two views are more important than a single view. This is a single image from a pelvic MRI, and this in a female patient where we are looking at a T2 weighted small field of view image showing the urinary bladder, a urethrocoel, and a cyst in the left adnexa. Here we are looking at two different images. The CT scan on the left shows a stone or a catheter in the renal collecting system on the left side, and there is a complex cystic lesion here. On the single face image we cannot tell whether this focus right here is enhancement or it is a part of the renal parenchyma or something hyperdense in the cyst itself. So we want to do a study with and without contrast. So this is without contrast, this is portal venous phase, and you can see the change here from this phase. The cyst shows peripheral enhancement, and that's what makes it a Bosniak 4 renal cyst, which is suspicious for renal cell carcinoma. Here's a patient who presented with a finding in the pancreas, and at the level of the pancreas we can see the ductal dilatation, and this hypodensity is causing that, and so this non-enhancing focus is pancreatic adenocarcinoma. And on the follow-up scan we see post-surgical changes where they have performed a distal pancreatectomy. You can see pancreas is absent here, and so this patient was treated for a pancreatic adenocarcinoma. This is a brain death study which is positive for brain death, and these are dynamic images acquired 2 seconds per frame in an anterior projection. You can see the tracer going in, and we see external carotid circulation, we see some activity in the face, we see some activity in the scalp, but no internal carotid circulation, and that's characteristic of brain death. Here is our next patient, another complication from a gastric lap band, where we see here on this coronal image that the band has slipped more inferiorly around the stomach, and the other images are also showing this. The band which is seen right here on the scout image should be at this level of the GE junction, and it has moved more inferiorly. So when you see this reported as a complication where the gastric lap band has slipped more inferiorly around the stomach, and that's when they become ineffective and the patient starts to gain weight again. This was a trauma patient where we performed delayed imaging to diagnose renal collecting system rupture and extravasation of excreted contrast. So if you're doing only portal venous phase in trauma patients, you will not see that finding. You may see some fat stranding around the renal collecting system, but when you wait and acquire more images, give kidney the time to excrete the contrast, then you will find the contrast in the collecting system and the extravasation into the retroperitoneal space, also seen here, which is suggestive of renal collecting system rupture. Here is our next patient, and we performed a multiphasic study starting with a non-con followed by arterial, portal venous, and delayed phase, and we find that there is extravasation of contrast right here in the transverse colon that becomes more intense with time, and the blood inside the lumen dissipates in the pattern or inside the lumen. Here's our next patient, and we are looking at multiple benign findings. So when you see focal uptake in the soft tissues around the femur head, like here, or around the greater trochanter, it is from enthesopathy. Frequently, patients have benign bone lesions like this one. It's a lytic lesion with thick sclerotic margin. That's a sign that it's benign and it's showing mild FDG uptake. And similarly, there is some faint uptake at the inferior border of the scapula bilaterally. This corresponds to the soft tissues, and this is called elastofibroma dorsi, another benign finding. So several benign findings that I wanted to highlight in one patient. Here is a patient where the chest x-ray shows that they have dextrocardia. The gastric air bubble seems to be on the right side. And when we look at the scout view from their CT of the abdomen and pelvis, we find that the liver is right here, and the colon is also reversed, where the cecum and the ascending colon are here, and then the transverse colon and the descending colon are on the right side. So this is a patient with situs inversus totalis. Next patient had a ultrasound of the scrotum, where when we look at the long axis view of the right testicle and compare it to the long axis view of the left testicle, we find that the right testicle is larger and it shows significant hyperemia compared to the other side. These are the measurements right here. Always look at the measurements, because any pathology that is affecting these small organs, inflammation, infection, tumor, that will make these, or torsion will make these organs larger. So comparison to the other side is very important. And so testis is larger, there is hyperemia. Also, the epididymis on this side is larger and is hyperemic. So this patient has right-sided epididymoorchitis. This is a DEXA scan where when we look at the lumbar spine, the region of interest have been drawn correctly, but there are extensive degenerative changes. We can see osteophytosis at several levels. The bones are hyperdense, and the T-scores are very elevated because of that. So they have also scanned the forearm, and we can see here that in the radius 33%, they are osteopenic. So usually we scan one or the other hip, but here we have not scanned the hip. So what is the reason? You go back to their chart and you find that they have bilateral hip prosthesis. That's the reason the forearm was scanned. This is another patient who presented with metastatic disease. We see here that there are hypodense large masses in the liver, and it turns out that their primary is in the colon, which is seen right here inside the hernia. And so a part of the colon has herniated into the left side of the scrotum, and that part of the sigmoid colon has this apple core lesion, which was their primary colonic adenocarcinoma. This is our next patient, a young female who presented with abdominal pain, and we see this very frequently where a hemorrhagic ovarian cyst is a cause of severe pelvic pain. And so here we find an ovarian cyst in the right adnexa, and it shows that hematocrit sign that we saw earlier, where denser components are in the posterior aspect, and it's more cystic in the anterior aspect with a pretty well demarcated line here, which is the hematocrit sign. This is our next patient, and the findings here are classic for acute appendicitis. Here in the sagittal image, we see this enlarged distended appendix with surrounding fat stranding, and here is the appendicolith as the ostium where the appendix joins the cecum. And this is the coronal image showing that this is retrocecal and pointing superiorly towards the liver. This is our next patient. They presented with a complication of acute pancreatitis where these multiple coronal images from their MRI of the abdomen in T2 weighted sequence shows a development of a fistulous connection through the diaphragm between the pancreas and the pleural space. So they have a pleural effusion, which is seen here, here, and here. And on these coronal images, I'm trying to show you how this collection tracks from the pleural space towards the pancreas, where there is a disruption in the duct of the pancreas. So they had acute pancreatitis leading to ductal disruption, leakage of pancreatic fluid, and which found a fistulous communication through the diaphragm into the right pleural space, and they have a moderate sized pleural effusion. So a pancreatico-pleural fistula. This is our next patient. They received a renal transplant in the right lower quadrant. So this is the transplanted kidney. That transplanted kidney shows multiple areas of cortical hypoenhancement. And so that suggests that they have acute pyelonephritis. Also, as a complication of the surgery, there is an abscess formation. We can see there is fluid, a focus of air, and thick peripheral rim enhancement. So acute pyelonephritis, which is most likely a infection that is coming from the urethra, bladder, up the ureter to involve the kidney, and a complication from surgery, which is abscess formation. Here is a chest x-ray, and in the next slide, I'll show you a correlative CT scan. How would you describe these findings? So the aortic knuckle looks okay, cardiac silhouette here is fine, left heart border, the right heart border, the lung fields are clear. But in the right paratracheal space, there is soft tissue fullness. And so also there is tracheal deviation towards the other side. So when you see such findings, think of a mass and ask for a CT. Here are two correlative images from their CT scan, coronal image and the axial image showing a large infiltrative mass. So this turned out to be a advanced lung cancer that was further characterized on the CT. There is some narrowing of the pulmonary artery branches. And if you scroll up and down, you'll get a better idea of how big is the mass. Is this the primary that is invading, or is it just metastatic disease? And so remember to ask for a CT and have a low threshold for asking for a CT when you see a abnormal finding on a chest x-ray. Thank you for watching.